Good evening, guys. I have discussion B for you. We're discussing how and why to transition from school based OT to adult or geriatric practice. Why transition from school based to adult/geriatric OT? Okay, burnout and limitations. Therapists like Sarah, a seasoned pediatric OT, often feel constrained by rigid school schedules and IEP cycles. Desire for growth. Many OT seek broader clinical impact and new challenges beyond the school setting. Benefits of adult and geriatric OT practices. Expanding opportunities, aging populations, and increased demand for rehabilitative services make adult OT a growing field. Diverse clinical impact. Working with older adults allows for more varied interventions, including mobility, cognitive health, and daily living support. Professional renewal. Transitioning can reignite passion and offer fresh perspective on care delivery. Would you like to explore how this transition intersects with cultural responsive frameworks or role uh, role aging strategies? I'd love to help you map out adaptation pathways or toolkit ideas. Culturally responsive practices in occupational therapy are about delivering care that honors and adapts to the diverse cultural identities, values, and lived experiences of clients. It's not just about awareness, it's about action, humanity, and justice woven into every stage of the therapeutic process. Here's a breakdown of these core principles and practices. Core principles of culturally responsive OT. Contextualize care. Therapists tailor interventions to the client's culture, worldview, and including beliefs about health, independence, aging, and disability. Narrative integration. Practitioners listen deeply to clients' stories to understand how culture shapes occupational or occupation and meaning. Critical uh, reflexivity. Therapists examine their own basis, assumptions, and power dynamics to avoid imposing dominant norms. Occupational justice. Care is designed to reduce health disparities and promote social inclusion, especially for marginalized groups. Practices across the OT process. Stage culturally responsive actions. Evaluation. Use culturally adapted assessments, consider language norms and family roles. Innovation, intervention, co-design goals with clients and families, respect traditional healing or caregiving models. Outcomes, measure success based on client-defined values, not just clinical matrix. Ethical anchors, guided by occupational therapy code of ethics, which emphasizes autonomy, benefits, and social justice. Practitioners are encouraged to pursue cultural humanity, a lifelong commitment to learning and partnership. If you're thinking about adapting these principles for world aging populations or cognitive health toolkits, we could co-create a framework that blends narrative prompts, intergenerational values, and culturally grounded outcomes. Measures want to sketch that out together. Okay, here we go with the rest of it for you. Adapting culturally responsive practices in occupational therapy is transformative, but it is not without its uh, fraction points or friction points. Here's a breakdown of the most common challenges, especially relevant to your work with aging populations and community-based interventions. Systematic and institutional barriers, rigid protocols, standardized assessments, and treatment plans often lack cultural flexibility, making it hard to honor diverse worldviews. Time constraints, deep cultural engagement takes time, something many clinical settings don't prioritize. Funding and policy gaps. Reimbursement models rarely support culturally adapted care or community outreach. Practitioner level challenges. Bias and blend bias and blind spots. Even well-meaning therapists may unknowingly impose dominant norms or overlook cultural nonsense. Limit, limited training. Many OT programs offer minimal exposure to cultural humanity, intersectionally, or community co-design. Emotional labor. Practicing reflexivity and confronting systematic inequities can be personally taxing and isolating. Client and community demographics or dynamics. Mistrust of systems. Historical trauma and systematic neglect may lead to skepticism toward healthcare providers. Language and communication. Non uh, non sensed cultural meanings may be lost without multilingual support or culturally fluent interpreters. Diverse definitions of occupation, what what's meaningful or therapeutic varies widely across cultures, requiring flexible co-created goals. Practical adaptation challenges. Toolkits and materials. Few resources are designed with cultural adaptation in mind, especially for rural and marginalized elders. Evaluation matrix. Success is often measured by clinical benchmarkers, not by culturally grounded outcomes or community defined impacts. Would you like to code design a challenge response matrix or an implementation guide tailored to your current toolkit work? We could map barriers to actionable strategies like integrating narrative prompts, intergenerational values, or trauma informed adaptations. Great question. Successful implementation of culturally responsive occupational therapy OT often emerges where practitioners co-design interventions with community communities adapt tools to reflect cultural values and measurable outcomes beyond clinical benchmarkers. Here's a few standout examples drawn from recent uh, lec- lectures and practice. Culturally adaptive pediatric interventions. A systematic review of pediatric OT interventions found that family-centered care with adapted to when adapted to cultural norms improved engagement and outcomes. For example, therapists incorporated traditional caregiving roles and spiritual beliefs into sensory integration plans. Interventions were co developed with families using multilingual materials and virtual storytelling to bridge communication gaps. Community based geriatric programs and moral aging contexts. Some programs have used life review prompts tailored to cultural milestones, uh, migration, church leadership, framing, legacies, integrated intergenerational storytelling, and trauma informed approaches to foster connection and healing. Measured uh, measured success through community defined outcomes like increased uh, participation in local events or reduced isolation. 3. Ethics guided cultural adaptation. Practitioners facing cultural conflicts, e.g., differing views on independence and disability, have successfully adapted the occupational therapy code of ethics to navigate tensions with respect and transparency. Use use collaborative goal settings or setting to align clinical priorities with cultural values such as collective caregiving or elder uh, relevance. Evaluation frameworks with cultural matrix. Some some teams have developed evaluation matrix that include um, cultural uh, con, congenious scores, client defined success indicators, community feedback loops to refine interventions over time. Would you like to co create a case study or implementation guide based on one of these models? We could tailor it to your work with rural African American elders or cognitive health toolkits, implementing culturally responsive occupational therapy practices, especially in aging and community-based contexts, requires navigating a complex web of challenges. Here's a synthesis of the most pressing ones, drawn from recent reviews and practitioner insights. Structural and institutional barriers, standardization versus flexibility. Many clinical tools and protocols are designed for uniformity, making it difficult to adapt them to diverse cultural contexts without compromising perceived validity. Funding limitations. Reimbursement systems rarely support time and intensive community engagement or culturally tailored interventions. Policy gaps. Lacking mandates or incentives for culturally responsive care. Means it's often deprioritized in practice settings. Practitioner level challenges, limited training. Many therapists report insufficient education on cultural humanity, intersectionally and systematic bias, emotional labor, engaging deeply with cultural narratives and confronting inequities can be draining, especially without institutional support. Implicit bias. Even well intentioned practitioners may unknowingly reinforce dominant norms or overlook cultural nonsense. Client and community demographics, dynamics, historical mistrust, communities with histories of medical neglect or systematic racism may be weary of healthcare providers. Language and communication, lack of multilingual resources or culturally fluent interpreters can hinder meaningful engagement. Cultural definitions of occupation. What counts as therapeutic or functional varies widely, requiring therapists to rethink goals and outcomes, evaluation and evidence challenges, lacking culturally uh, valid matrix. Most outcome measures don't reflect community defined success or cultural relevance. Sparse research. There is a shortage of high quality studies evaluating the long term impact of culturally responsive OT, especially in geriatric and rural settings. Would you like to co-design a challenge response matrix or build out an evaluation framework that centers cultural uh, congruence framework that centers cultural congruence and community defined outcomes? I think it could be a powerful addition to your toolkit work. Culturally, competency in occupational therapy shines when practitioners move beyond surface level awareness and embed cultural understanding into every layer of care. Here, wait a second, guys, paper. Here are some compelling real world examples that reflect this depth. Life review with rural African American elders. Context. A therapist co-developed a life review toolkit with elders in a southern Black farming community. Cultural competency. Prompts were tailored to reflect migration stories, church leadership, and land stewardship. Sessions integrated gospel music and oral storytelling traditions. Outcomes increased engagement, emotional resonance, and intergenerational dialogue. Okay, guys, so that is B for you. I'll be back on shortly with C. Give me a little bit, please, and I'll be back on with C for you. For now, Gator Wellness, take care, folks.